So, greater trochanteric pain syndrome, GTPS, lateral hip pain, is one of the most common things we see at the hip within physiotherapy. But what are some of the steps we need to take in order to rehab it? In this video, we'll go through everything. So if you're ready, let's dive in. Hey guys, Khalid here, welcome back to Clinical Physio. So we know that GTPS is a condition that can really irritate patients. It can be really painful and therefore really affect quality of life. So first of all, let's start with what are some of the do's and don'ts of GTPS rehab. So the most common mistake we see is when patients are given ITB stretches and or piriformis stretches. Ultimately, we know that with GTPS, the patient's symptoms are going to be exacerbated by hip adduction as it compresses the gluteal tendons. These stretches will absolutely contribute to this, and so I don't give these stretches out to my patients with GTPS. In a similar vein, for hip adduction, another factor we see when patients are struggling is when they are given exercises in a hip adduction position. An example of this is a clamshell exercise, because the patient has to use their gluteal tendons whilst in a hip adducted position, which just tends to aggravate them further. And the next common mistake is rushing into high intensity exercises too quickly. So we avoid hastening the progression to high intensity exercises like bounding, hopping, and jumping. This is because if the hip abductors that push out to the side are too weak, these exercises can force the hip once again into hip adduction, causing irritable compression and hindering recovery. So instead, what exercises should we be thinking about? Well, in the early stages, I like to talk to my patients about isometric hip abduction and bridging. So in terms of isometric hip abduction, the patient is lying on their back with a belt around their knees. Here, we simply ask the patient to push their knees apart against the belt, holding the position. One thing to make sure of is that the patient does not start the exercise in a hip adduction position where the knees are touching, because that irritates them, as we said before. So if you want, you can place a pillow in between the knees to make sure this is comfortable. Then, with bridging, we ask the patient to lie on their back and simply push their bottom up in the air. This should be done with a controlled, slow movement rather than a powerful, forceful, fast movement. We can start with the hips abducted, again making sure that the knees aren't touching in that adduction position, and you can even use something like a TheraBand to make sure the patient is doing this nicely. Now, in the midphase, one of the most common mistakes I see is when patients are given exercises which are too painful for them. So I'm going to show you some exercises here. Key point, make sure they're comfortable for your patient before you send them home with it. So we might think about squats, a really nice and simple exercise which we can do with a TheraBand around the knees if you want in order to maintain hip abduction. We can also think about things like crab walking, stepping side to side with a TheraBand around the legs to make sure that the hip stays in abduction. We can also think about things like step-ups, once again making sure that the knees stay straight so that the legs are in an abducted position, preventing that adduction of the hip which may well irritate it. Then when we're thinking about the late stage rehab, here the crucial parts are improving strength and also improving the control between hip adduction and abduction, as we've said throughout the video. So, examples of exercises you might use might be forward step-ups. You may also think about things like lateral step-ups. And you may think about exercises that push the hip into abduction with control, such as a fire hydrant exercise, as you can see here. You may also want to think about plyometric exercises for your high-level athletes who really have to put power and speed into the hip. So, some general tips for rehab along the way. First of all, focus on pain management. Ensure the patient understands that they need to keep their exercises with pain levels under control, and we don't want them to aggravate their symptoms during their exercises. So make sure the patient knows they can tailor their exercises if they find that it's becoming too uncomfortable. Next, focus on control rather than power. As we said with the bridging, we need to focus on that balance between hip adduction and abduction, particularly in the early stages, to make sure the patient isn't moving in an adduction position. Next, reps and sets. You can start with 10 to 15 reps for the control-focused exercises across 2 to 3 sets. As you're moving on to power, you may reduce the number of reps, but increase the weight to try and make sure that patient gets stronger. Next, you want to add a gradual increase in the patient's general activity as their exercises get harder. This is crucial to make sure that if they're doing the right exercises, they're not hampering this by doing too much activity away from their exercises. And finally, whilst we've said throughout the video that in the early stages we want to avoid hip adduction, in the latter stages you may try and test the hip by seeing how your patient responds when their hip is in adduction during their exercises. This is so that we get them really strong and reduce the risk of GTPS in the future because your patient can cope with that hip adduction demand. So guys, I really hope you've enjoyed this one. If you have, please support us by smashing that like button and subscribe to the channel for all our best updates. We've got loads of resources as well on our Instagram account @ClinicalPhysio, and we've got loads on our website too, clinicalphysio.com. My name's Khalid. Thank you so much for watching. See you soon here on Clinical Physio.